Okay, so we'll just give it a few seconds just for people to start rolling into the session, and then we'll do some instructions and get sorted.
Thanks, Nathan. Would you rather we muted between things? Is that better, or what's
It's absolutely up to you. Obviously, if there's any background noise and stuff, which there tends not to be, feel free to mute. But it's pretty easy to do either. So whichever one you feel most comfortable with.
No worries. I've shut the cat out, so we shouldn't be disturbed.
So have I, but it's never that simple. It's not usually that
We'll
simple.
be scratching at the door now. Yeah.
Absolutely, yeah, that's right. Okay, fantastic. So we've got a fair few people in, which is brilliant. So let's get started, shall we? So I'll just introduce myself a little bit, and then we'll get everybody else to introduce themselves. So good morning, everybody, from wherever you might be. Thank you so much for joining us on sort of a midday on Monday. Really appreciate you guys being here. So I'm Nathan. I'm from the European Pain Federation. And I'm joined today by what was going to be 4 brilliant speakers. We might have 3, but we certainly have 2 fantastic speakers here at the moment with us. So we're going to introduce those, and then we'll get started with a couple of questions and discussions, which is going to be focused around pain science education for pain management and behavior change core principles and its applications to pain. So again, I'll give the speakers a chance to introduce themselves just in a moment. A few points about this webinar for everybody who might not have seen one of these before. This is a recorded Q&A session, which means that it's a brilliant opportunity for you to ask questions to the speakers who are here today. There is a Q&A function at the bottom of your screen. You should be able to highlight over the mouse, and there should be a question and a chat function there. Just to let you know, you can ask your questions anonymously too. So please feel free to ask questions anonymously if you feel like you don't want to put your name on that. I use that all the time when I'm in other chats, so feel free to do that, everybody. We love passing the questions on to the speakers, and I'm sure they would love to hear from you and hear your interesting questions. There's no wrong questions. It's just to facilitate a discussion. Hopefully we can have a chat about everybody's ideas. There's also a chat area for general discussion. So if you want to put in some random comments, or perhaps if you have any resources that other people might find useful, maybe you can direct us to those in the chat as well, which would be absolutely brilliant. Okay, so I think it's also a really good opportunity for the speakers to bring up important issues or relevant issues. So if you feel like you have questions for each other, Bart and Karen, feel free to nip in and ask each other questions as well. Hopefully we can get a real fruitful discussion, especially with it being about pain education and everything else that we hopefully want to cover today. So perhaps we can have just a brief introduction from Bart and Karen to get us off. Just to notice that Anne, unfortunately, isn't able to join us for the webinar today. So we hope that there might be an opportunity for Anne to get involved with the future session, but unfortunately, Anne won't be part of this webinar today. And Lorimer, he is still aiming to be here, so we're hopefully being able to get in touch and get him involved. So he might join a little bit later in the session, so you might find that he'll pop up during the session, maybe halfway through a question, but hopefully Lorimer will be joining us very, very shortly. Okay, great. So let's get started. Just as you know the deal, guys, the clockwise thing around the Zoom call to introduce. Bart, good morning. Thank you so much for joining us this morning. How are you doing? Give us a little bit of introduction about yourself.
Yeah, good morning, everyone. Good morning, Nathan and Karen. My name is Bart Morlion. I'm by training an anesthesiologist. I'm directing the Multidisciplinary Pain Center of the University Hospitals in Leuven in Belgium. But over the last years, maybe you got to know me because I was heavily involved also in leadership of EFIC and in educational initiatives. But this is a past period. So now I'm focusing on a few educational initiatives like this one, and I'm happy to be part of this webinar.
Amazing. Thank you for being involved. Absolutely. Yes, some people might find the name familiar, but thank you so much for being involved. And Karen, good morning.
Good morning, Nathan. Hello, Bart. Thank you for inviting me to be part of this panel. I was part of the Behaviour Change talk a couple of years ago, and I think that's why I've been asked to come today. I'm a health psychologist by training. I am mostly academic, but I did spend a few years working in the NHS, working with patients who live with complex regional pain syndrome. So that's where my interest in pain came from. I'm a qualitative researcher, so I'm really interested in patients' lived experience and trying to understand, what it's like and how we can learn better how to help them live well with their pain conditions. What else do you need to know? I don't know if you need to know this. I'm based at the University of Chichester, which is right on the south coast of the UK. And apparently Chichester claims to be the sunniest place in the UK. And it is sunny today. So there we go. Thank you.
It's just making it just a little bit obvious that it's nice and sunny as I close my blinds a little bit. I'm in the northeast, so quite far away. But hey, if you want to claim all of the sun, that's happy. We can do that. That's fine. That's great. So thank you so much for your introductions, guys. Really appreciate it. And it's great to have you involved. We do have a couple of questions that we want to ask based on the talks. If anybody hasn't already seen the talks that Karen refers to and Bart was obviously involved with as well, they're on the EFIC Academy platform. So please feel free to go and have a watch of those. There's lots of other videos as well, but mainly involved with pain education and behavior change as well, which would be really useful. So if you have any questions around those, that's great. And again, that's another reminder to ask some questions as we go through. Okay, guys, so perhaps I could just start us off with a general one, and I appreciate that you won't be able to speak for all aspects of some questions that we might have. So hopefully there'll be some questions from the chat that people will put in so we can answer those as well. So perhaps we can go to Bart. When we're thinking about pain education and the behavior change and trying to initiate some form of behavior change or reconceptualization, or at least develop understanding of pain, what do broadly clinicians need to consider when we're trying to deliver pain education or trying to initiate behavior change? What are the types of things that they would need to consider?
Yeah.
I appreciate that might be a complex question.
Okay, but I'll try to give you an answer from my perspective. So to be clear, I'm not a psychologist. I'm not a behavior psychologist. I'm not a psychomotoric trained physiotherapist, for instance. Nevertheless, if I want to deal with my patients in especially chronic pain, because that's the major part of my clinical job here at the University Hospitals in Leuven, then you have to acknowledge, and that's the way I teach also my fellows and residents, that you always need to start from the definition of pain as a biopsychosocial phenomenon. And you shouldn't forget this. We are trained, for instance, as physicians to, even nowadays, although it's improving a lot, but still nowadays, we tend to stay focused on these biological principles. And that's a major challenge because most, to give you one example for my center, in my center, mostly people are at a terminus station. They have been walking around in the healthcare system for many of them for many, many years. They have put new hope on new developments, on technical interventions, on very advanced diagnostic procedures, and they're frustrated because in the end, they land up in a center where actually after a good evaluation of the biological factors, we start off with a much broader analysis and assessment, looking also in these psychosocial issues and psychosocial backgrounds. And so it's a very difficult encounter with many patients because one of the often heard remarks during a first visit, for instance, is, "Oh, Professor, please don't tell me that it's between my ears because that's what my environment thinks of me." And then actually, you need to kick off already with neuroscience pain education. So education is one, in my eyes, and I want to be clear, I do not have the academic background as a clinician towards these things, but we did also quite a lot of research on the role of science education. There is in these patients really a need for behavioral change. And this behavioral change, or you have a lot of time to do it on an individual basis as a physician, but I can assure you that we are also limited in the time we can afford for each patient. So yes, we try to head for motivational interviewing, to give some alternatives, to work on the patient. So have you ever thought that if 35 different therapies do not work, that maybe there is no cure for your problem? So we need to shift them from a cure-based concept toward what we call a more acceptance-based concept. And that's often a very tricky one, where it's important that you motivate the patients to get this broader look, to go to our psychologist, to go to our physiotherapist, to the social worker, so to involve a team, and to keep in mind that maybe the physician will tell you that there is no cure possible for your problem. And this can be very confronting. And in some patients, you really need to head for a more structured pain science education program to establish this change in this behavioral change. And most patients are actually not accepting this from the start. Some patients are already a little bit pre-contemplative, and so we need to kick them a little bit to contemplation in this. And that's the reason I offer, or we offer in our center since over 25 years, pain science education sessions. However, in the past, it wasn't called like this. This is a newer semantic term which turned up a few years ago. But actually, that's what we did. We want to prepare patients and their important others, because that's a very important one to take. And then head for, if you educate your patients, then also in my experience, it gets a little bit easier to get them from this pre-contemplation. Maybe I should consider that there is no cure possible for my problem, and I should also be open to a broader perspective of therapies. And that often leads to the situation where we can open the patient towards also what I then call to the patient, because it sounds sexy, it's train the brain concepts. And heading for more mind-body directed therapies. So that's the framework where we work in. And there is also the important role of the physician to be part in this mindset and to be part in a team, to use the same semantics, to talk about the same things, not getting different messages by different team members. So this was quite a long answer to your complex question, but I think it's a nice opening for the further discussion.
Absolutely, and I think you're absolutely right. It's a long answer, but it's a big question. You know, you've done that very well, because that was actually quite a broad question to start off. So thank you for that, Karen. Any thoughts to add to that?
Well, a bazillion. There's so many things, as Bart said. There's so many things to think about here, and you know, if we go back to, I think it was the 60s, someone called McCaffrey said, "Pain is whatever the person experiencing it says it is," and I think that's an important thing we have to remember. And Bart mentioned the biopsychosocial model as well, and that EFIC, I think, released a video today on Twitter explaining it, which was really, really nice. If you want to look at that, that's a really nice explanation. I was thinking of kind of stepping back a bit in terms of what clinicians need to consider when they're helping individuals understand pain. And I was thinking, okay, so asking the questions, how much the person with pain wants to know. You know, maybe they don't want to know all the ins and outs of it. So starting from where they're at and what do they know already and what do they want to know? Why do we need to increase their understanding? What is it we want them to get? So explaining why their understanding needs to deepen so that they're on board. literacy levels of the person that we're working with. So, are we able to because as we've said, it's really complicated and complex. How good are we at translating this information into easier to understand stuff? And I used to sit on a research funding panel many years ago, and everyone had to write a lay summary of their proposal. And that was the bit where most of the proposals fell down, because academics and clinicians are usually really rubbish at writing in a way that's easy to understand. So have we practiced as clinicians turning our complex information into something that's easier to understand and meaningful? What else was I thinking about? How confident are we in explaining it and explaining whatever it is we want to explain about pain? Does the person have other conditions? Lots of people have multiple conditions now, and so are we able to take those into account as well? And then what resources do we have to help explain all of this? To kind of the older I've got, the more visual I've become, and I need to see things, and I need to see simple pictures and things. So and I'm seeing there's lots of really useful stuff coming out now that we can make use of as clinicians and practitioners and researchers, in terms of understand and helping understand all the information. So I agree with what Bart said, and then I was thinking, okay, let's take a step back and think about those kinds of things as well. Does that help?
Mm-hmm. No, absolutely. And there's a few points there that you've made which resonate with myself. Can we use these other forms of or the ways of delivering this type of information to help them understand? And that comes after, do they need to understand, and why would they want to understand it from a patient perspective?
Can I jump in? Just
of course, please jump in.
My students, we have a bell when I'm teaching, and it's called the Rodham's Ramble Bell. If I go off at a tangent, a student has permission to ring the bell. But it's reminded me, one of the first times I was working with a patient, and we went all the way around the stages of change model that Bart was kind of talking about in his answer. And I was so excited. It's the first time I'd helped someone navigate around this, and they didn't care they'd been random modeled. They weren't interested at all, but I was really excited and wanted to share that with them. And that was a really good lesson to me, to think, okay, so what do they want to know and what's exciting to me? And they might be quite different things.
Mm-hmm. Absolutely.
Yeah.
Absolutely.
So, and feel free to ring the Rodham's Ramble bell if I do.
Maybe I need one of those bells myself, so don't worry about that one. No, that's fantastic. It's really interesting, and it just kind of shows that it's complex, and I appreciate everybody who's kind of watching might have lots of things to add to that, other things that might be important to consider. So if you do, everybody put them into chat, and that can facilitate a discussion as well, which is great. We do have a couple of questions, which is brilliant. So the first one is, and feel free to address anybody who feels like they might be able to address these questions. So it says, if we start from the concept of a predictive brain, has therapy so far focused too much on changing the consequence of the prediction? And wouldn't improving the prediction actually be more sustainable, or wouldn't improving the prediction actually be the more sustainable intervention? So education, not only of patients, but also of the, I guess, the environment and the social reality in which that's delivered. Do we perhaps need to focus more on that?
Yes, that's another. They're all going to be big questions, aren't they?
These are great questions. And look, I would say if you feel like, this is something that you could go away and look at, perhaps invite them to contact you directly. But again, it's these are going to be difficult questions. Yeah.
I mean, I don't know that I mean, I'm not going to pretend that I know a clear answer to that, but changing the consequences of prediction, that's quite an interesting question, isn't it? And we have all this cognitive behavioral therapy, which is all about challenging the thinking and things like that might help with that. But also it's about life context, and that's become a bugbear of mine, that we're not always very good at taking into account our patients' life context and understanding what it's like for them living in their world. So we might be giving them all sorts of tools and teaching them and training them and helping them do things, but then unless it translates well to their life context, then they might get stuck on implementing what we're saying. I don't know that I've answered the question. I've written down change the consequences of prediction and improve prediction. Maybe if we get a better understanding of their life context, we can then help them think about how they can maybe change what they're expecting. I don't know. I'm kind of fishing in the dark. I'm wishing I hadn't stepped in straight
No,
away.
no,
Maybe
absolutely.
Bart can
Thank you.
step in and save the
No,
day.
no, please. I appreciate that rather than just the stony silence that I get sometimes from the questions. So no, thank you. And again, this is a discussion. So I really appreciate that. And yeah, it's a very, very sort of complex question. It's a very, very good question. Perhaps maybe just highlighting something else that we need to perhaps consider.
Our brains
Maybe
are.
I can add something to this. I cannot discuss the actual question. I cannot discuss. What I can actually, what I appreciate in this question is what is also my feeling and of many others working on a daily basis with these patients, that actually day in, day out, we're confronted with patients which are actually also results of social reality. That's the reason I like this last sentence in the question. And I completely do agree that if we want to improve suffering in patients with not only chronic pain, I see it more as also in mood disorders and so on. So there is, it's also a product of the society. And if we want to really get into a preventive action on a population level, then it's, in my eyes, much more important to go for social structure, reinforcing safe networks. I just give some examples where we on a daily basis notice that it goes wrong or went wrong in the past in many of our patients, and that they're very prone. So it has been written by others, and as for instance, also Francis Keith once said, pain should be seen as a transdermal phenomenon. And he didn't meant a transdermal patch of a drug, for instance, but a transdermal of the societal environment. And I think that's quite important. And if we want to work more on a preventive level, that's the meta level we should aim for. But that's, of course, not only the responsibility of healthcare providers. That's a more broader responsibility, which would lead us here now too far, I think.
Yeah, for sure. No, thank you. Hopefully, and yeah, I think you're absolutely right. That thinking about the last aspect of that question was probably the best way to go about that one. So hopefully that's answered, and that's really interesting perspective for sure. We do have another question from Pete Moore. Pete Moore, who I know quite well, is a person with lived experience. Morning, Pete. Thank you so much for joining us. He says, why isn't supported pain self-management coaching not taught to trainee doctors while in medical school? And of course, he mentions there he's asking for the 1 in 5 people in the EU are living with persistent pain. Why is it? And Bart, you mentioned earlier some when you're teaching to clinicians and maybe fellow colleagues, perhaps maybe not the self-management coaching from that perspective, but why is it that we're really struggling, or it seems like we're struggling to teach healthcare professionals and trainee healthcare professionals about delivering pain education from the biopsychosocial perspective, or are we struggling?
Yeah, we're definitely struggling, and I'm personally struggling also at my university. And if there is a change in the curriculum, hours on pain and chronic pain are the first to cut again. So why? I see some reasons for this. At least in those countries where you do not have a good embodiment of people, physicians, for instance, because I'm talking now for a medical school, and the question is about medical schools, is that in most countries, including mine, we're not recognized as a specialty in its own right or a super specialty in its own right. That means that in every single discussion, you have to fight the group of surgeons, the group of internal medicine, the group of obs and gyn, which have their clear pillars in the school system, in the medical school system. And so, yes, pain, yeah, we should maybe do a few hours, but then not examine it, for instance, and that means that the level of hours you can spend on this is so low that, of course, I would like to, and I try to give also some examples of metaphors they can use, our young colleagues can use if they want to start in explaining and starting neuroscience pain education. But you can only do this in 30 minutes. And if you then still have to add supported pain self-management, it gets lost. But I appreciate Pete. We know each other for many years, and I know he keeps on using his hammer and bashing this nail. And it's but we mustn't recognize that yeah, maybe it's a personal failure that even at my university I wasn't able to expand the level of training in these matters. And that's what's happening. There are differences. There are also good signals where in some medical schools there are actually far more hours spent, where also the biopsychosocial phenomenon and biopsychosocial model is thought in a more common way, because it's not only relevant for us as people working with people in pain, patients in pain, it's relevant for every part of medicine. So, and I noticed that that's improving. So hopefully it's a slow train. It's not a fast track train, but we will get there at some stage.
Karen, any thoughts?
Yeah, I like Bart's positivity there, that we will get there. I'm gonna hang on to that and hope that's true. I agree with Pete. Isn't it ridiculous that such a big percentage of a population experiences something and it's not mirrored in the training for all health professionals? Same with psychology, you know. And Pete's basically written a curriculum for us with his toolkit, hasn't he? So I mean, it's there for us to steal, plagiarize, work with Pete to build in. So it does seem on the face of it really difficult, really weird that we're not doing that. But yeah, it requires, I guess, us to lobby our professional bodies to make the changes to the curriculum and to step up and push more for that. And I think EFIC's got a big thing going on about education training this at the moment, haven't we? So that would be a really useful tool to build on.
Absolutely. And I think one of the steps that we're trying to do is understand where we currently sit, you know, and what levels of how hard that it might be difficult to sort of describe and define pain education within the curriculum. But we're trying to find a better way of having a look broadly through Europe, what's being delivered and what's the quality and what type of things are we looking at. And I guess that could be a real good first step to looking at how we can address that. But look, it's a complicated picture, and interestingly, when you think about the concept of delivering this type of curricula, you think, oh, this is quite difficult. But actually, there's a lot of resources out there, Karen, like you mentioned. There's a lot of really good resources, and we've all seen these being delivered on small scale in selective universities, usually because one of the faculty members has an interest in pain and are able and comfortable to deliver that to trainees. And I guess if you don't have that, you don't have somebody who's comfortable, who's passionate, who's enthusiastic about delivering this content, it won't be delivered. And often the priority is on other evidence-based sort of treatments and solutions for the management of pain, right? Yeah, it's difficult. So yeah, hopefully that answers your question, Pete. And again, yeah, keep banging those doors, which is fantastic. Another question, if you don't mind us going through these questions. There's some fantastic ones coming through, so thank you so much, everybody. So this one is from Anonymous, says, how can we communicate to vulnerable patients, i.e. individuals with intellectual disability, who may be non-verbal about pain education, and best to support them? It's a fantastic question. You know, not only how well are we delivering the current information, but when it becomes inappropriate for some people in whatever shape, you know, can we adjust? And are we doing well to do that? Are we able to involve those select people who aren't able to understand that? Often a good example here, due to intellectual disability.
I think there are already some really good resources out there. I think the one that I use when I'm teaching about pain and pain management is Tamar Pinku's video with the balls of plasticine and how it feels, and as a way of coping, and that's very simple, very easy to understand, very very visual. But I'm sure we can do much better, and I think we need to be making sure that our stuff is accessible and inclusive, and that people see themselves in the literature and resources that we are putting together. So I don't think it's insurmountable. I don't think what we're doing is good enough yet, but I think that would be something that I used to do when I was in practice. I was like a magpie, and I'd collect all of these different things, and I'd collect children's books. They're often brilliant at explaining, and I use that in my teaching, and they're often really good at explaining complicated things that we need to understand. So not being a perfectionist, or finding ways to communicate. There's one about a cat and a bird that find a way to communicate in the end through painting, and they think they have nothing in common. And so I rely on things like that really help convey the information that's complex, but in a simple, accessible way. So there's no reason why we can't do that. I don't know that we're doing it well enough yet.
And are those resources initially made for that intention of delivering pain in sort of story format, or have you just taken?
No, I've taken them
applied
and twisted it. Yeah. So if I'm talking about pacing, I'll find a children's story that's relevant, and things like that. So, and I'm learning much more about literacy at the moment. I've just trained to teach adults to learn to read who can't read yet. I'm going to be assigned my first reader very soon, and I am excited to help someone open up the world of books and things like that. But I've got one eye on thinking, how will this inform my practice? And how can I use the learning from that in terms of how I'm teaching someone who can't read to read? How can I build that into what I'm doing with patients? So I don't know if that answers the question, but those are the thoughts.
It does. The only reason why I ask is I guess the ability for somebody like yourself, which is amazing, is to look outside the box for resources and find ways that they can facilitate that communication. For you to be able to do that in the first place, you need a deep understanding of what you want to deliver and the information that you want to deliver. You also need the access to other bits of information. So being able to deliver this sort of information in that way, it has a real reliance on the clinician and their ability to recognize those opportunities and take advantage of those and be comfortable with doing that, bringing in those types of resources. And to somebody who's been living with pain for 30, 40 years, and here's a children's book, and being able to make that work it's not easy.
No, I was inspired. There an amazing health psychologist, Jane Wardle, she spoke at a conference, and I think she was doing work on obesity, I think, at that time, and she was doing a keynote, and she talked about how she'd started reading Pig Monthly, and everyone was like, well, where's she going with this? And at that point, pigs were being bred to be leaner. And so she was just reading that to see if there was anything she could learn from that completely different field and bring it into psychology. And so hearing her speak at that conference years ago has really inspired me to remember to kind of pop my head above the parapet and not get just completely drowning in health psychology, because there's so much to learn outside of psychology, outside of medicine, outside of where we are. And I think that's where multidisciplinary team working comes in. And that's really important too. You can learn so much from each other and see your bit in a really different way by talking to someone from another profession. And that then sometimes enables you to think, okay, well, that's a good way to explain something.
No, fantastic. Thank you. And Bart, any thoughts of,
Yeah, thank you. Most has been said by Karen already. I just want to point out that, of course, if you look at a question, disability, I would rather say there is a cognitive continuum where you're working with. And the challenging part of a good oil team is to pick out those people who have the cognitive ability to be part of a group. education program, because of course we have also the economic realities. We cannot head for 4 to 8 hours with every individual patients, but to pick out those patients where you think, okay, with my level, and that's what we do the whole day. We work with metaphors, with stories, examples, reflections on own emotions of patients. But that's something you can deal with in groups, which is very efficient in a team. But on the other hand, you need to then establish also a few escape gaps for those people where it wouldn't work in these groups. And that can be very challenging, because part of these cognitive disturbances are also driven by chronic pain as an ailment, as a condition. And concentration disturbances and memory disturbances actually can be very extreme during a phase of chronic pain, not because the person had concentration disturbances or memory disturbance. No, it's part of the ongoing process of chronic pain. And so that's very challenging. It needs a team. It needs also to be addressed very individually. And that's also for us as physicians, of course, quite challenging. Where can you take time to go to levels, for instance, and using materials which actually were developed for 6 to 8 years old, which is quite already a good level to start with, even for adult education.
Yeah, absolutely.
Yeah.
For sure. No, that's fantastic, and that's really interesting. So hopefully that's answered the questions. Thank you so much for the questions, everybody in the chat. Feel free to pop some more in there. We obviously have a great opportunity to ask Karen and Bart directly if you have any questions. So please keep those coming. Perhaps we can shift slightly from pain education more towards the core principles of behavior change, which is also included in today's discussions. So what do we mean by sort of the core principles, and what do we need to do to or what parts of those core principles do we need to address for individuals with chronic pain? You know, what type of behaviors might we see in clinical practice? I don't know if Karen, Bart, whichever you'd like to start.
I would like to kick off because it's not my specialty, and not background, but I can maybe list the challenges and the behaviors we are encountering on a daily basis, which is actually a sick theory which doesn't match the reality, unrealistic expectations of patients, then very external locus of control. It's very technical, but meaning, okay, you're the professor, please give me a solution. So putting away their own responsibility or neglecting their own responsibility in this whole. So these are behaviors, also turning around day-night shift, very immobilizing activities or lack of activities, then also non-acceptable or socially non-acceptable use of these resources. It's something, if we go to the meta level of the social dimension, also these patients cost a lot to society by their ongoing requests for new scanners, for new diagnostic interventions, for surgical interventions. So this is also part of behavior. And so these are the challenges we encounter. And now I'll listen to Karen to give us the core principles.
No pressure. Thanks, Bart. Yeah, some of those things you mentioned, I remember from my time in practice as well. Some of these issues. So if we go back to kind of core principles of behavior change, the thing I'm talking as a health psychologist here, in the psychological models that we tend to use, and Bart mentioned the stage of change model, and there are lots of other models. One of the common ones that's being used at the moment is one called the COM-B, And I think my colleagues in our session focused a lot on the COM-B in our presentations. And it looks simple, but looks difficult as well, the model. It's taken years. Susan Mickey and her colleagues spent years developing this. And there's a book that came out, I think last year, by Joe Hart and colleagues, which is talking about, I've written it down, training to change practice, behavioural science to develop effective health professional education. So it's looking at health professional education, but it explains how to apply the COM-B in a really accessible way. It's the best explanation I've found. And I can email you afterwards with the title if people are interested in it. The hardest part of behaviour change is defining what the behaviour is that you want to change. It's like when you're planning a research study, the hardest part is nailing down the question. Once you've got the question sorted, everything else falls into place. So nailing the actual behaviour that you want to change is tricky, and it'd probably be different for different patients. And so defining that is important to do with the patient. So we might, as clinicians, think this is what they need to do to change, but actually the patient might have a different priority that's more important to them. So working in collaboration with them to work out what behaviour to focus on first would be really important. And then if you're using the COM-B, you then divide, you look at the different elements that make up behaviour. So you've got capability, opportunity, and motivation. And they're each split up into different things, different elements. And so you're working out, maybe the person is really motivated to make a change. Maybe they have the opportunity to make the change, but maybe their capability. So maybe that's where the education needs to come in. They need a bit of training to help them with their skills or help them feel competent, or maybe they need a bit more knowledge in order to make the behaviour change. So it's a really useful way of trying to pinpoint where to focus your intervention. It might be they don't have the opportunity, maybe they haven't got the resources, or maybe they haven't got the support, or maybe they don't know how to ask for the support they need. So maybe you do some communication skills training. So you use the COM-B to nail down the element that needs to be polished. And then within that, there's a whole list of interventions that you can then draw from to design your intervention with them. So it's a really useful model that takes you through on a step-by-step basis to help with behaviour change. And you can do it at a big scale as well as at an individual scale. They've been using it, the COVID, whilst being horrendous, was also a really good opportunity for these kinds of models in terms of hand washing and all of that kind of stuff to look at how we can improve that. I had a student who worked in prisons, and the message "stay home" was really upsetting the prisoners, because that was where they wanted to be. So she took the information and rewrote it suitable for the prison population in terms of keeping their hand washing going, but used the COM-B principle on a larger scale. So you can do it on big and small scale. So you narrow down the capability, opportunity, motivation, work out which thing to focus on to help with their behaviour change. But you need to work together with that person to narrow down what behaviour needs to change.
Mm-hmm.
Does that make sense?
No, absolutely. And I think I've seen the COM-B before, where I think you have maybe 2 or 3 sections within the capabilities and things. So it's very, very well explained. So absolutely, I think that could be something useful for people when they're looking to develop interventions, as you mentioned, however big or small that you believe that they need to be. You mentioned there about sort of changing behaviors. What type of behaviors are we looking to increase? I know it might be different for sort of everybody, but what are sort of the key behaviors that we're looking to increase, and how might you do that? Or is it a blank sheet? Well,
I mean, I guess there are common things, aren't there? So if you're in pain all the time, and sometimes it's worse, but it's hovering around this kind of level. And the pain scales aren't that helpful, because half of them aren't available to them. The lower half, are meaningless. So it might be you're afraid to do the exercises the physio have recommended for you. So maybe there's fear avoidance. Maybe you're afraid to do that, although you're not going to do any more damage. You're afraid that you are going to do some more damage. So maybe there's some opportunity to help change the behaviour and increase their engage. I hate the word engagement. I've just said it now, but increase their engagement with behaviour. And if you look at acceptance and commitment therapy, there's a chap, Russ Harris, who's written a lot, and when you're trying to set goals, he has a really brilliant phrase: is don't set a goal that a dead person could do better than you. So for me, that would be trying to give up crisps. You know, a dead person could do that really well, but what my goal could be was, when I feel like having crisps, I'll have an apple instead. You know, and so thinking about the goals is don't set something that a dead person could do better than you could do, but also think about a behaviour that you're working towards doing more of. Pacing would be another one. You know, we're all rubbish at pacing. It's really frustrating to have to think about, you know, doing things so that you're on a more even keel, but that was a regular behaviour. Communication skills, another one, you know, how to ask for the help that you need rather than the help that people are offering you. Bart mentioned sleep. That can be a really useful thing to help people change their sleep patterns so that they're sleeping rather than being awake all night and dozing through the day, helping change their sleeping patterns. So there's lots and lots of different things that behaviour change can play a role in. Yeah. Did you want to come in? Have I missed anything or said anything wrong? I'm going all impostery now.
No. Once again, I want to open it further. I think health behavior in general is something, all these principles which have been well studied should be applied also, of course, in chronic pain, even in those situations where you already have the chronic pain. I think that working on general health behavior remains a prerequisite to help these patients.
Yeah, I agree.
Absolutely. No, thank you for that. So hopefully that's some information for everybody, not just kind of things to be looking out for, the kind of things that you should really be perhaps addressing or potentially addressing, but how you can do that as well, and how to come to those decisions, which is really useful. Thank you so much for the questions. There's a few comments in there. If anybody has any questions, we're obviously coming towards the end of the slotted time. So if you do have any burning questions, please feel free to get those in. There are some resources in the Q&A as well from Pete, which is great. And perhaps maybe one of the last questions before we round off. Where do we need to go with patient education with regards to increasing behavior change or increasing knowledge? We've kind of mentioned earlier that we need to increase the quality, the quantity. How might we go about doing this? You know, does it have to be on a societal level? Does it have to be on a governmental level, sort of a really sort of top down, or do we need to make sure that we're giving our clinicians and our people who are passionate about this information the platform to rise up and go higher? Is it on the patients to gain that information and push that information from their clinics, which then drives that information? How can we go about just increasing the quality and the quantity of pain education, and make perhaps reference to behavior change as well if you need to?
Everything you just said, Nathan, that's the answer. Everything you've just said, from top down to bottom up. And, you know, it's great there's more of a move towards recognizing the biopsychosocial model, but the medical model still rules in many places. And that's probably why patients come expecting and hoping to be fixed, because that's what you expect. So, you know, that kind of thing. Pete talks about supported pain management, and I think it's really important that we remember the supported bit of that. I think sometimes pain management goes to just being, you know, you've come in right now, go manage your pain, but the supported bit is a really important thing that we need to remember. The other thing I was thinking about is awareness of us as clinicians. I think one of the questions you were throwing around before we arrived was about what are the barriers to increasing patient knowledge, and my first one is us as clinicians. We're a big barrier. There's all that work by and I'm not sure how to pronounce the name, but Rodham and colleagues that have looked at how we as clinicians often are unconsciously judging, particularly patients living with persistent pain. That's a really interesting body of work there. So the unconscious bias that we might hold, and maybe that comes back to the lack of focus on helping and teaching about pain in our training. I think we're doing better at recognizing the patient is an expert in their own experience and being more willing to collaborate with them when we're working with them. I think something we could do better, and this is a systemic problem, at least in the UK, I don't know other systems, but we've become more and more and more specialised. And the NHS was never set up to deal with long-term conditions, but the system has become more and more specialised. But there's a growing number of people with multiple long-term conditions, and we deal with them separately. And there doesn't seem to be anyone that has a overarching view of stuff. So we might be advising them to do one thing, and the other clinicians are advising them to do something for their, and it might be that it's not helpful. So someone needs to have a bigger picture. So there's a systemic problem, to answer your question, but there's lots that we can do within the system to start making changes. When I was in practice and I was starting to get a bit overwhelmed with all of the, the greater and greater demands, I stumbled on a book by Robin Youngsome called something, there's time to care, something like that. And that was that changed the way I thought about a lot of things, about how we can create time. And someone, I wrote their name down, but in the British Journal of General Practice has just written a think piece about how we can make pain less painful for people. And they've talked about what they're doing in their clinics to create the time to talk to the patients. And so there's lots of stuff, there's lots of positive stuff going on. I don't think we hear so much about it because as human beings, we focus on the negative all the time. That's not to say it's not bad and there's more to be done. Mm-hmm. But I think we need to remember to look at us as being a potential barrier as clinicians and not just look at the patients as well. Yeah. Another Rodham ramble for you. I apologize.
No, absolutely. And I think, look, I think you're not the only person who could ramble on about the answers to this question. We obviously do several webinars here, and we had one recently with a fella called Joe. It was two people who lived experience with pain, and I asked them, I said, what's the most important thing for you? And they quite simply said, just to believe, just to believe us. And it's the most simple thing as that. But as you mentioned there, the barrier is ourselves, in believing this and getting the real good balance of being the expert, but also being collaborative in your approach. And I guess we're struggling with that a little more than what we should be. Bart, any thoughts to?
Yeah, just echoing, heard all good things already from Karen. I want to point out or have two comments adding to this. First of all, this webinar was discussing a lot of neuroscience pain education, but we need to position it also. It's just one of the armamentaria we have in the management. And on the other hand, although I'm a strong believer and also in our own follow-up of patients and what we published, it shows that you can change a few variables, especially in MSK pain, where but you're not decreasing the pain itself. That's something important. So you should use the neuroscience pain education. It's not a holy grail to so put it in perspective. And then about behavior, coming back what I said in my previous comment is, I think that knowing that, for instance, in chronic pain, over half of all the problems are MSK, musculoskeletal pain problems. It should start in kindergarten with health attitudes, with health behavior. And so this is something which will take generations. But I'm convinced that getting back to the social role or the role of the society in the whole problem of chronic pain, but also other chronic conditions in general, that there should be much more responsibility of the society in delivering also the instruments, including not changing behavior, but creating the correct behavior from the start in the education of our youngsters and our population. So putting it once again on a higher level. I think that's one of the property or visions you get when you get above 60, that you get away from this individual point of view towards what could we do on a meta level.
Absolutely, yeah, and I agree, and thank you for bringing that up. It's a very good point that needs to be reiterated. You know, there's people like ourselves, and there'll be people on this call who are passionate about pain science education and stand by that its effects and what it can do for someone who's living with pain. But we need to keep recognizing, and we need to remember that it's only part of the picture that needs to be delivered, and needs to be supplemented with some very, very good care from all different aspects. And it's not just a case of, if we tell people this information, if we deliver this information, it's going to be better. That's not the case. It's very, very complex. So thank you for that. It's really, really interesting. Fantastic stuff. We've got a couple minutes. I'd really love to find out what you are individually doing up to in the next couple of months. You might be busy today. I appreciate that. So thank you so much for sharing time. But maybe in terms of research and maybe specifically to pain education and behavior changes, are you guys active in research at the minute? Have you got anything going on? Is there anything that we should be excited to hear about?
Oh, I don't know. That's a scary question to answer, isn't it? What I'm excited by might not be what you guys are excited by. I've not got anything on the go at the moment, but I'm working with some students that have just finished their big studies, and one of them has looked at multiple morbidity and how people cope, and what when they've got chronic pain but other conditions. So we're working that up into a paper, because that's something that's becoming more and more important, that people are living with more than one condition. And the life context thing is something that I've still got to be in my bonnet about. So I think about that, and I'm trying to infect all my students in my master's teaching as well with that, and make sure that they just roll their eyes when I mention life context now, but at least it's now in their heads, and they will go out and they will know that it's an important thing to ask about. So that's where I'm at the moment.
Fantastic. Bart?
Yeah, I'm quite involved in general education, and I'm shifting from more the medical school education towards the general public education. So I do roadshows on the story of chronic pain, including many of these pain science educations modules I use for my patients. Offering it also in a general public. So that's more a crusade, I call it. And then I stay involved. I do my own sessions here in my pain center, because I didn't mention this, but what we learned is that the involvement of a physician therapist remains important also in science pain education. So we do it together with the psychologist, with other medical disciplines, with physiotherapy. But for the credibility and the motivation of patients, it remains a good point if the head of department or the treating physician, the consultant, also pops up during these sessions and tells his or her story. So that's what I try to do. And I remain involved in some international projects, but I'm not the key driver in these projects. You know, Anne and Lorimer are doing a lot of projects, and in some of them I'm still involved.
Amazing. No, amazing. Busy. And that's a great point. You know, that could have been a whole part of the discussion today was, you know, is it at public health level that we need to address this, and how might we go about that? And I know there's some fantastic stories and fantastic initiatives that are being run at the minute in the public health sector, which hopefully are helping towards our goal of increasing, you know, knowledge and for pain management. So I guess we'll have to end it there. You know, we've got a minute or so left, which is fantastic. Thank you so much for being involved today, Karen and Bart. Really appreciate your feedback. Some very, very interesting stuff. Hopefully everybody has found it super useful. As I mentioned earlier, this webinar is recorded, so everyone will be able to access the recording of this session. I think it's via YouTube, so keep an eye out for that. And you can obviously access the others as well on the EFIC Academy Education Platform, and you can find a link to that in the email that you've received as a reminder for the session today. So please go and check those sessions out. So yeah, again, thank you so much for everybody for joining us today, and I wish you a fantastic rest of your day. And again, Bart and Karen, thank you so much for joining us.
Thank you for the invitation.
Thank you. It was a pleasure. Thank you for moderating. Thank you, Karen, for picking up all those things where I'm not an expert.
Well, and ditto to you, Bart. Oh, it's a loving. Isn't this wonderful?
Thank you so much, guys. Really appreciate it. Have a great rest of your day.
Take care.
care.
Bye-bye.
Bye-bye.